With us today are Andrew Biernat, former president of both the New York State Association of Health Underwriters, now the National Association of Benefit and Insurance Professionals, and the Greater Central New York Association of Health Underwriters. Currently, Andrew serves as Vice President, Strategic Business Advisor for Gilroy, Kernan & Gilroy in New Hartford, New York, and has served as a broker advisory board member for several upstate health plans. Next, we have Ed Farrell, the Executive Director of the Retired Public Employees Association. Ed joined RPEA in 2014 and is its longest-serving executive director. His prior association management experience included the American Institute of Architects and the Conference of Mayors, and also work in both local government and the state legislature, where he was Deputy Budget Director for the Assembly Ways and Means Committee. Finally, we have Nick Rangel, who has been the Executive Director of the Legal Aid Society of Northeastern New York since last December.
It's almost my anniversary.
Happy almost anniversary.
Congratulations.
Yep, congratulations. Prior to joining the Legal Aid Society, she served as the second deputy counsel to the New York State Senate Majority, Office of Counsel and Program. Nick is also a Region 2 deputy for the Hispanic National Bar Association and leads the National Lawyers Guild chapter for the Capital Region. Okay, our end-of-day panel discussion tries to get perspectives from the key stakeholders on the challenges the constituents they represent face on our issues, approaches policymakers should consider to address these concerns, and efforts the healthcare system should undertake to improve equity, affordability, and access. Just as a reminder to all of you in the audience, to submit a question, use the Ask a Question function on the conference app. You should all be pros at that at this point. Okay. Our first question, we're going to talk about empowering patients through public health. Public health has been a theme throughout the day here. To level set for the first few questions, public health is the science of protecting and improving the health of entire communities through promoting healthy lifestyles, researching disease and injury prevention, and directing, preventing, and responding to infectious diseases. Work is done by public health nurses, disease control investigators, and community health workers, to name just a few. What the Commissioner of Health said this morning about public health is that it's helping all the people all the time. So that's sort of the framework for public health. For each of you, each may have a different perspective, but what role does public health play in empowering or supporting the constituents you serve towards good health? And what are some of the barriers to empowering patients to take control of their health care? I'll start with you, Andrew.
Well, thank you. And first and foremost, I just want to follow up to what Eric was saying. For those of you who may not be aware, our association, NYHPA New York, comprises the interests of about 6,000 insurance agents, consultants, and brokers throughout New York State and adjoining states. We support universal health care, and we believe market innovation is the way to get there, integrating existing public plans with other market-based solutions. We're often perceived as simply a distribution channel, and I just want to kind of alleviate that myth. We're risk managers. We work with employers and individuals throughout the United States to help prevent, mitigate, transfer, assume, or finance risk. So our job, first and foremost, to our client is to identify where that risk may be. Once we bring on a client, then our role changes a bit, and we actually become an advocate for them and their employees to help enroll and educate with regard to their benefits programs. But to your question about public health, we believe that the role of public health is critical. The promotion of education and prevention of disease to empower individuals is of paramount importance. I can think back to one great example of a great public health policy, and that was back in 2009 when Governor Cuomo decided to move forward on a New York State marketplace exchange. And he reached out to many different stakeholders, the unions, non-for-profits, government officials, our association, who all participated in the design of one of the best-run public exchanges in the country. And that was because, again, he sought input from many different factions. On the converse, recently there was a regulation that was proposed by the New York State Department of Financial Services with regard to PBM management. And that regulation would have driven prices up for consumers by about $250 million. And that would have been a barrier. Again, many times we think that, throwing a new cost into the mix is going to be borne by the company, but ultimately it's going to be borne by the consumer. So that's something that we're very concerned with and we're very knowledgeable of. So with regard to public health, we believe that it's critical that we work collaboratively with every stakeholder.
Nick, would you like to go next?
Sure. So I'm Nick Rangel. It's really great to be here. I think I'm here with two hats, one as a large nonprofit employer and also as an employer that provides free legal services to low-income people. And so my sort of first instinct is always the legal services aspect and connecting really important health access to the legal work that we do. So I have to pitch, medical legal partnerships as part of the public health paradigm, the piece that's kind of missing with a lot of the public health work that we see across the state. So adding a component where we're saying, yes, there's a best practice, we have these recommendations, public health can really develop the data and the initiatives, but without the legal aspect to protect or provide access or ensure that lower income and marginalized communities can actually achieve those goals, you're always going to have that gap. And so that's kind of the perspective I think that I come from as far as how public health really interacts with the work we do.
Thank you. Ed.
Thank you. It's an honor to be here. It's an honor to follow the Thurman Thomas Foundation, he and his wife. So I'm humbled in that regard. Let me just say, in terms of my members, retired public employees, the vast majority of whom are Medicare primary. So their interaction is mostly not with public health entities, but in the private sector. Let me just tell you our one major experience with public health, and it was awful. And it had to do with vaccinations for COVID. We were in phase 1. It was medical workers, other essential workers, and then us, people over the age of 65. We were phase 3 in the first group. So they took care of the medical folks, they took care of the other essential workers, and the methodology for getting to people over the age of 65, the Department of Health made 2 major blunders. One, they assume everyone over the age of 65 has a computer. And 2, that they have transportation. The appointment process for us, which was refined by the time it got down to most of you folks, was horrible. You had to go online, you had to try and make an appointment, and generally it said, no appointments available. The end. So you had seniors, older folks, if they had a computer, or if they had to have a grandchild come in or somebody help them or go somewhere else, there was no opportunity to actually make an appointment when one was not available. It didn't say, well, leave us your name, we'll call you back, we'll do something. It was dismissed, no appointments available. We had people here in Albany going to Potsdam in Plattsburgh, and most of the places you went to were inaccessible. You had to have a car to get there. And not everyone over the age of 65 has a car, nor a computer. So our initial access was not good. It was very bad, actually. And it was only later on when the health department said, let's call in the reserves. Let's bring the vaccines to the people. Let's use the county health departments. Why are we making people drive to SUNY Albany or SUNY Potsdam or the fairgrounds and the state fair? So finally a little light bulb went on, but it was horrible.
Okay.
And I'd like to follow up to that, Ed, because that is a very interesting observation. And I think we talk often about customer experience, client experience, and how individuals are interacting in the healthcare system. And to your point, quality of care plays an integral role. And I think there have been many folks who have been disenfranchised over the past few years with some of the experiences that they've had in the healthcare system. I can speak to my own experience with my own daughter. And, you know, from inadequate transmission of medical records to, as you said before, delays in actual care. That's a barrier. That prohibits individuals from further accessing the system when they have a bad experience. And it's something that we need to be cognizant of as we move forward, because I believe things can improve dramatically. We just have to take those initiatives and take those steps. But great observation.
Right. Now, that is a great observation. And it kind of does lead into the next question, which is a question for Nick. You are running a community organization that's focused on addressing systemic inequities. So what do you see as the public health challenges? We just heard a little bit of it. And what can the rest of the system do? The hospitals, the health centers, the health plans. What can we do to start overcoming those barriers that we're talking about here?
Yeah, absolutely. So I think what really the heart of what we're talking about here too is a loss of public trust in public health. And once you lose that trust, it's much harder to get back. And we know that there are marginalized communities that have had their trust broken from public health for decades and centuries. And so there is a real gap in trust there with many, many communities across the state. And from our perspective at Legal Aid, little of the legal medical partnership, because that's what we do. You see higher rates of asthma, for example, in low-income and Black and Brown and BIPOC communities. And there's a lot of reasons for that. One is that is where polluting factories are likely situated. And also there is a lack of access to healthcare at all stages. And there's a lot of sort of pieces that get built into there. But with the legal medical partnerships, you have an opportunity to tie actual living conditions, habitability of where people are renting or the homes that they're staying in, to the health outcomes of those families. And being able to tie those conversations together would go a long way to ensuring that there's better access and more equitable access, both to better health outcomes and the rights that people have to living and breathing and going to school in healthy environments.
Okay, thank you. Okay, so the next question is for everyone. Given the current financial challenges facing the state, the current and upcoming fiscal years, if additional state and federal funding is not available, what kind of partnerships does the government, community organizations, and the marketplace, what should we be developing to fill that gap? And what I'm hearing so far is solutions that don't actually need more funding, right? I'm hearing we need partnerships, right? I'm hearing we need better relationships to fix some of this stuff. It doesn't even, so maybe rewording the question a little bit, is this a financial issue, or is it really about better communication and better partnerships?
I think that's a great point right there. My earlier comment, education is critical. And I think helping individuals understand what their options are is critical. We're going to talk a little bit later about transparency, et cetera, but I think from a public health perspective, better education could be instrumental, more so than just throwing more dollars at the system. That's my opinion.
So medical legal partnerships do take a tremendous investment in funding, both to fund the legal aspect, the communication between medical partners and community providers, and informing the public about the availability of those resources and like a comprehensive approach. But there's sort of this other sort of piece here in accessing healthcare in an emergency setting and the reimbursement rates to hospitals for the rate at which people go to the emergency room instead of getting ongoing regular health care. And there's a bill that was passed in legislature this year, that I think it's called like ounce of prevention. It would create kind of some uniform hospital practices around financial assistance, and it would help ensure some uniformity for low-income people who can't afford their health care to get financial assistance to help both reduce their medical debt and also encourage people to get health care before it's emergency, which does take a public investment, and that it does require financial support.
Okay. Okay, so it's not just, we can't just solve it with great ideas. We have to have some investment as well. That's what I'm, yep, that's my summary. Okay,
100%.
got it. Ed, anything else you'd like to add?
No, I think I'll pass.
Okay. Okay. So the next topic we want to tackle here is diversity and equity. Another question for all of you. The Thomases were just here talking about the importance of advancing equity and inclusion in the healthcare system. Are there efforts or policy proposals in the marketplace or that the state should be pursuing to support these efforts that you can think of? Ed?
Well, I have an example that's very specific to my membership, many of whom are in the New York State Health Insurance Plan, NYHPA. And there's 500,000 retirees in the state retirement system, half of whom are in NYHPA. And when you're in NYHPA, you pay your premium, you are a retiree, and eventually you become Medicare eligible. So there's one, how would I say it? There's one provision of care that is available to you up until you reach the age of 65. If you are under the age of 65 and in NYHPA and you need skilled nursing facility care, you get up to 120 days. Once you turn age 65, and for no other reason, you get 0. Because you become Medicare primary. They said, well, all right, you get the Medicare provision, which is 20 days as opposed to 120. So we said, well, the only barrier to continuing a benefit which you had is because of your age. You lose this benefit for no other reason than because of your age, that you turned to age 65. We worked with the Department of Civil Service. We had a bill passed. Assemblyman McDonald was here earlier. He was one of the sponsors, along with Neil Breslin, our senator, passed unanimously in each house, saying, when you turn age 65, your benefits should not go down, period. So, only because you turned 65, no other reason. The governor vetoed it with a whole batch of other vetoes saying it didn't have an appropriation, and so said it was going to cost $65 million, which we find hard to believe. But anyway, if anyone needs this care, skilled nursing facility care, it's most likely older folks. Why, as a state policy, state of New York policy, would you take this benefit away from people who would probably need it the most? So we're pursuing it. We went through all sorts of provisions and said, well, it seems like discrimination, and they didn't say it's discrimination, they just said it's not illegal.
Right.
So
Okay.
that's an example.
Okay, thank you. Andrew, anything you want to add?
From our perspective, obviously, one of the things that we believe in and we're pushing is equity in the healthcare delivery system. One of the big problems that was mentioned earlier, the consolidation of providers, that's a huge issue, and it's creating healthcare deserts out there in certain pockets of the state, which, again, affects folks' ability to access quality care. So, we're focusing a lot of our attention on those matters, loss of providers, loss of specialty providers, medical malpractice insurance premiums, which are rising, driving more people out of the system. That's primarily been our focus.
Okay, thank you. Nick?
I think on the kind of, employer side, there's an inequity in the large and small employer community rating practices, and there's a lack of education and information for employees seeking or who may have higher health needs, knowing how to identify employment that's going to have better coverage for them. I have a disability, and this has been a lifelong challenge for me personally. As a legal services provider, we see a severe lack in behavioral health sciences and access to behavioral health, which has a strong connection to, for example, housing instability. We see that as having outcomes for homeless or unhoused people and prolonged homelessness. We see inadequacies in discharge planning. So if you are a low-income person and you rely on Medicaid or Medicare, you're more likely to be discharged earlier than what your care really needs. You're also more likely to be discharged to family members who do not have the skill, financial support, or capacity to care for somebody, let's say somebody with a health need who also is experiencing dementia. How do your family members just start taking care of you if you are also dealing with issues of financial stability, right? And we don't have enough assistance or services for the aging population generally, and that's acute in the lower income communities. And so you do see more families kind of overcrowding in housing because they both can't afford services or healthcare services. That person doesn't have access to facilities on a long-term basis, and people just don't know where to get assistance or help with caring for their elderly.
Okay. And a lot of what you do is try to assist those folks to get the support they need. And Andrew, you've mentioned education about what is available, right? Often families waiting for someone to be discharged from the hospital, they need something when that member gets discharged and they don't get it.
Right.
So you do advocacy. Are you able to do some advocacy for those families and help them? Are there partners out there in the healthcare delivery system, whether it's social workers or the health plan's care manager perhaps, that can help you coordinate some of those things?
Absolutely. We just don't have enough public investment in making sure people have the advocates there to help them access the resources that are available. Okay. And there just aren't enough, right? Like there aren't enough providers serving aging populations. There's not enough access to behavioral health sciences at all, let alone for people who are marginalized or low income. Okay. There is some legislation that was recently passed that would help keep medical debt off of people's credit ratings, credit reports. We know that medical debt is one reason that low-income people avoid going to a healthcare provider or going to the hospital when they have an illness or an injury. And what that does is, it doesn't mean they aren't sick or injured. It means they wait until the very last minute after it becomes a very severe illness or a harder to treat injury, because they're so afraid of that medical debt. And I do think that reducing debt loads and helping people navigate how to get financial assistance for their medical needs is very important as well.
Right. Okay, thank you. Andrew, go ahead.
I was just going to add to Nick's point about behavioral health. And also, I think, Ed, you mentioned it earlier too with COVID. I mean, telehealth is a huge opportunity, and I think one of the good things that came out of COVID, if you will, is this opportunity now to leverage technology to help individuals who are stuck in these deserts get necessary help. But our members oftentimes are helping individuals understand what all their options are, whether it be through the state or whether it be through a private carrier or whether it be through a telehealth type system. So I think all of those things can be really impactful.
Okay. So I'm going to move around from the questions a little bit because we talked about medical debt and financial assistance. So I'm going to kind of jump into cost, addressing healthcare costs. So you mentioned legislation related to uniform financial assistance policy in hospital and prohibiting hospitals from reporting medical debt to a credit bureau. What policies in the state do you think, what other policies could the state implement that could generate cost savings? And what kinds of policies of the state are barriers to that? We could be here all day answering those two questions. But I'll start with you, Andrew.
So back in the year 2009, 2010, when the state first looked at the Affordable Care Act, we were one of only a handful of states that changed our community rating laws from 50 to 100. And early on, we said, that's going to be problematic for many employers because employers are looking to do the right thing for their teams. They're looking to provide benefits to reward, recruit, retain, and retire team members. So they're also looking for quality, but at a cost, something that's affordable. And as we thought, what ended up happening was we saw a lot of businesses that were in that 50 to 100 market basically exit our market here in New York. Some of them went to other states, changed their situs. Others joined PEOs, professional employer organizations, which for those of you who may not be aware, basically PEOs are an aggregator of risk. So they're able to take smaller groups out of the community pools and, not saying good, better, and different, but it definitely decimated the New York's small group market. So we think that it would be advisable to reconsider that and also look at the potential to allow some of these smaller organizations to potentially self-fund, which in New York, we don't have the reinsurance to allow that. But we think that could be very helpful in helping to mitigate some of these cost increases and allow some of these employers an opportunity to get back into the New York small group market.
Okay. Ed.
Let me just address cost from the other end, the consumer end. Contrary to popular belief, a lot of public employment retirees are not fat, sitting fat and pretty. 24% of them have a pension under $10,000, and 43% have a pension under $20,000. So one, they're lucky to have a pension, but contrary to popular belief, they don't have a lot of money available to spread around. One of the things that we're seeing is a potential attack on benefits primarily for Medicare primary enrollees. The biggest example is New York City, where they wanted to take all of their retirees out of Medicare and put them in a Medicare Advantage plan. They'd have great benefits, not lose any benefits, but the city would save $600 million a year. $600 million in savings, but you're going to not lose any benefits, which is hard to believe. You turn on the TV at any time, you see these Medicare ads. They're all coming at us. They're coming for us. And we see it happening in local governments. There's an employer group waiver plan called EGWIP, where localities can form their own Medicare Advantage plan, which is what New York City was doing. But we see it around the state. And retirees are moved involuntarily from original Medicare to a Medicare Advantage plan with the premise that everything will be hunky-dory. So you worked your whole career with the assumption that when you retired, this would be available. That was always the case. Now we have this push toward Medicare Advantage. Almost 50% of people on Medicare are in a Medicare Advantage plan. A good number of them made that choice voluntarily, but we are now seeing this movement of involuntary movement without any say on the part of the enrollee.
Could I just add to
Yes.
that point, just for a point of clarity too? As we all know, the fee-for-service model isn't one that I think is going to sustain us long-term, so there's movement toward value-based care. And basically, traditional Medicare is a fee-based model, whereas the Medicare Advantage is value. There's a capitation per individual, and so that's why we're seeing part of this migration, to your point. But I do agree, it becomes very challenging when people have worked their entire life for a benefit and been promised it, and then at the last minute get it taken away from them. So that becomes unfortunate.
Right. Nick, would you like to add anything here?
I agree that community rating, would have a large impact. So my organization just recently in the last couple of years moved into the under 100 to an over 100 nonprofit. Congratulations, Lassie.
Yes, congratulations.
So,
yes.
but what that also means, but our grants don't increase at the rate of the cost of healthcare. So while our healthcare costs went up when we hit large employer, and annually our healthcare costs increase at a pretty rapid rate, kind of particularly right now. Our funding does not, right? So we're faced with really tough decisions on cutting services to the low-income people that we are here to serve, or keeping salaries extremely low. We're far below the median for the area and nonprofit legal service providers. We don't get to do as much of the education, the public outreach, all of that. We don't get to do as much of the professional development and the investment in staff to make sure that they are also out there doing the best work that they can. And I think it's important to remember that the public investment in the access to healthcare also has to have a component where we're thinking about public service and public servant employees.
Right.
Yeah.
Okay. No, excellent point. So transitioning from that point, Andrew, I want to focus on you for a second. Employers pay a large percent of their employees' healthcare. You work with employees or employers of varying sizes. I'd like to think that the employers have more leverage over how this works than maybe they think they do. I don't know. How do you feel about that? And what can we do? What strategies do we have that we can work with the employers to start addressing the cost of healthcare?
So before I give you some of our ideas as an association, I'm a steward of behavioral science. I'm always looking for ways to improve for our teams and as a society as a whole. If you enjoy reading, there's a great book called The Best Team Wins by Adrian Gossage and Chester Elton, and they're behavioral psychologists. And basically in their book, they took a look at about 850,000 employee surveys, and they went and talked to the managers of some of the top performing organizations throughout the country. And in summary, there was a part of the book, an excerpt that really caught me. And they had been speaking with a fellow by the name of Tanner Elton, who was one of the lead advertising executives for Amazon. And he had a very diverse group of individuals throughout the country that he was managing. And by all metrics, his production, his culture, they were blowing it out of the water, and they couldn't figure out, how is this guy doing it? So when they interviewed him, he basically said, there are 3 tenets that I have my team live by. First and foremost, no excuses. We're a company that believes in figuring out how we're going to get things done. We're not going to sit around and say it can't be done. Second was do it. You could sit around and ideate in a board meeting all day long and come up with great ideas, but it isn't until somebody stops and actually makes a phone call or does something that we get progress. And the third thing, which really struck me, was the concept of fail forward. And the concept is, in the best interests of your employees or your organization, you try something different. You try something really big and bold. You try to hit a home run. And if you fall flat on your face, we're going to applaud you for making that effort, because we're all going to learn. So with that concept in mind of failing forward, some ideas that our association has that can definitely help mitigate some of the cost increases and give better access to individuals would be the establishment of high-risk pools for large claimants. I mean, 1/3 of healthcare costs, high claimants, are borne by about 1.2% of individuals or specific members. And so when thinking about that, we know that exists. Why can't we leverage some high-risk pools in New York so that we can help mitigate some of those high cost increases that employers and employees are very fearful of? Second, expand managed care. I believe managed care worked. I believe that it still works, and I believe having a quarterback for your healthcare needs can be extremely beneficial to individuals. Better management of chronic conditions. We talked a little bit about fee-for-service and that model, moving again toward value-based payments. We believe that is going to be something that is going to be very impactful. Continuing all the ACA provisions, as well as reduce redundant medical facilities. We talk about healthcare deserts, but in certain regions and pockets of the state, you have multiple facilities that are doing the same thing. Controlling prescription drug costs, and lastly, allowing those mid-sized groups other opportunities, those between 50 and 100, other opportunities for either self-funding or modified community rating, which could be extremely impactful. And we know in Pennsylvania they're doing it successfully, and in New Jersey as well. So those are just a few ideas.
Thank you. Ed, anything to add?
Well, I'm not a big advocate of changing around all the formulas, et cetera. But we are aware of a certain bill which did pass this year, which would allow DFS to take a peek when the price of a prescription drug goes up more than 16%. It does not mean the company could not do it, but they could get called in and say, what's going on? Why did this go up? 20 other states have this bill. It passed both houses, awaiting delivery to the governor. It seems like a good thing. And some of this was spurred by the EpiPen a couple of years ago when they raised the price 1,000% or more for no reason, just because they could. And so we're going to keep an eye on that, urge the governor to sign it.
Okay. Nick, anything you want to add?
Yeah, I think, so one thing that, I agree, and I don't want to repeat anybody's comments, but one thing that I see as an employer is that there's a kind of a lack of transparency between the plan options and the proposals that I can collect from the marketplace. So I can say, hey, to different providers, I'd love to hear your proposal. This is what we're thinking. And when you read those proposals, the detail in what would be made available at what cost is extremely difficult to discern or to identify, and it's very, very difficult to identify that across or in a comparative way. So one of the sort of arguments for kind of a single payer model is because of that transparency and the lack of bargaining power that employers, especially nonprofits, actually have in the marketplace. And one example is with our particular plan, when we first asked for a proposal, the rate increase was going to be, the proposal we got back was a 14% increase for this year. And if I did not have assistance and support from experts in the field, as an employer, how would I know how much bargaining power I have there? We had a counter proposal, and then we sort of just kept guessing until they said, okay, we can do 7%. And so if you're an employer and you don't have an advocate on your team, and that's a large employer, right? And we're a professional setting, like, how does that play out for smaller nonprofits, for smaller organizations and companies? How does that play out for individuals? Like, well, how do I know that I can negotiate different costs or that I can appeal a decision that declines to cover something that I've been prescribed? We don't. And so that education and that information, that transparency would go a long way to help reduce our costs individually and as organizations, but also kind of lends its support for the single payer model, the New York Healthcare Act, because of those benefits that we think would arise from that model.
Okay.
Can I add a
Yes, I
comment?
would
Because
like you to
that's a
follow
great
up. Yes,
point.
please.
Transparency, critical, but there is another barrier in the transparency thought process. And I'll give you an example of a client that I just talked to yesterday who had an employee that had a bump on her leg. And because of her high deductible plan, which was very, very high, she didn't get it looked at. Fortunately, after about 8 months, when she did get it biopsied, she was okay. But the point being that even with transparency, if the cost is too high, individuals still can't get that access to care. But I do agree, transparency is essential. I mean, we have transparency in everything else in our life that we purchase, but healthcare, it seems to be a little bit more challenging.
Yes. And just to kind of spiral off of that a little, piggyback off on that, we haven't talked a lot about dental and vision health, but so often we're talking about our healthcare coverage. Even on the employer side, we pay over 90%, 95% of our employee healthcare, but we don't pay dental and vision. And many employers don't. That's 100% employer contribution. And we kind of forget that health and dental care is part of our healthcare and can lead to these other underlying health problems, right? Like gum disease can lead to heart disease or blood infections. So there's this whole slew of illnesses and that people leave untreated for a very long time because no one wants to go to the dentist, but also dental care is harder to get through your employer. Right?
Okay, well, that's helpful. Anything else you want to add about maybe you work with employers of different sizes, so how do you help them have leverage when they're making those kinds of choices? To Nick's issues about no transparency or little transparency, a little bit of confusion, sounds like. How do you help?
A good portion of the time is spent educating, right? I think a lot of the solutions are surround being educated, but those employers who are large have much more opportunity for savings than those that are small, to Nick's point. So
Right.
there is that challenge there, but there are opportunities because there are many different levers within the healthcare system that can be pulled. From an employer perspective, census management, compliance with certain regulatory schemes. The ACA, I mean, originally when the Affordable Care Act first came out, people were trying to figure out, how do I insure 95% of my population so I don't get fined? Well, then it was quickly realized that maybe some of my team would be better off going to an exchange and me paying that fee versus paying for it out of my own pocket because the costs are just exorbitant.
Right.
So there's a whole bunch of ways that we can help those employers.
Right. Well, it also is more important that we address costs as well, right? Or you don't start out looking at a 14% increase if we can address the costs in the system, right?
Sure.
So, right. That would be good. We need all of your ideas on how to address the costs in the system. Okay.
I would just note, so I heard Andrew kind of make a comment about how large employers can reduce costs because we have the ability to offer less robust health care coverage. And when we think about what that means for employees, particularly people at the lower end of our salary scales, it is important to note that equity in healthcare starts with employers because we don't have universal healthcare. So if we're saying, how do we ensure that there's better health outcomes in low-income communities, working poor communities, or beyond that, traditionally marginalized communities, as we're diversifying our workplace, we have to start as employers, and we have to make sure that our employees have the best access to healthcare that we can.
Yes.
If I could just add to that, and I'm sorry if you misinterpreted my thoughts, because I certainly am not advocating for lower quality care. As a matter of fact, part of our education process is helping employers understand that by making the investment in employees' well-being, the productivity and the morale of organizations is far superior than those who believe that investment in employee benefits is an expense. So to your point, we're always educating to help folks understand that by making this investment, your team is going to be much healthier. They'll lead more productive lives. And as I talked about the lifespan of an employee, we want to bring on young people. We want them to stay with our organization, have a great experience, and then retire on time with a good retirement program. And then the next set of employees come through. So that's what our hope is.
Right. Okay, so building on that equity point, this is a question for you, Andrew. You supported the Coverage for All bill in the past year. So did we, right? That would give coverage, expand coverage in the essential plan to income-eligible, undocumented individuals. So from your perspective, what is the impact of having something like that get enacted on equity? Seems like an obvious answer, but.
Yeah, I mean, it was, first off, thanks for promoting that bill, and we followed suit quickly because we saw the opportunity there. First and foremost, we're looking at helping individuals who wouldn't have access to care. And in New York State, we still do have charity care through the HCRA taxes. And in evaluating the benefit, the pros and the cons, and as we know, when people get early intervention, when they can go to a primary care doctor and potentially prevent disease, it's far less costly to us as a society. Right. That point was easily recognized, that it was far less expensive from a financing perspective to insure those individuals and help them with good health versus waiting until they needed to go to the emergency room and then bottleneck the system by using urgent care and emergency care, which is far more costly, but more importantly, detrimental to their health. So we were very supportive of that bill.
Okay.
And there's also a community aspect because people who are undocumented live in our neighborhoods. And so on an infectious disease level, for example, if you have an outbreak of something like measles because somebody is unvaccinated, it's not just the person, it's the whole community, and it spreads. So it's smart on a public health level to make sure everybody in your community has access to healthcare so that we're all starting out in a safe environment. We're going to the same shared places with people who are safe to be around.
Right. Well, and that's a public health aspect as well, right? Thank you, right, for making that point. Okay. Let's see. We've covered a whole lot of these questions. Okay, here we go.
I would just make mention earlier, somebody mentioned the gentleman in an earlier conversation who was sitting at the end, and he said, you know, there's this feeling out there that healthcare is terrible, and you know, on a daily basis, I hear a lot of stories, and I would just leave you with this one story that I think can shed some light on where I hope the future is. And in the 1950s, at Johns Hopkins University, a professor by the name of Kurt Reichter did a study of mice, and he took 20 mice and he put them in a pool, and they observed them, and after about 3 to 5 minutes, all the mice drowned. So they took a second cohort of mice and they put them in the pool. And at the point where they were just getting ready to drown, they plucked them out, dried them off, and held them for a minute, and then put them back in the pool. Now remember, these mice were exhausted and their counterparts drowned. Guess how long those mice were able to continue swimming?
12.5 minutes.
60 hours, 3 days. And they surmised that when they eliminated hopelessness, the mice were able to persevere. And so people out there are counting on us to help them figure out the future. And I think we can do it, but certainly something that stuck with me.
Great comment. I love it. Ed, go ahead.
Yeah, before we wrap up, we didn't really talk about the New York Health Act. And
Right.
we, retired public employees, are specifically mentioned in the act. Right in the bill language, us. It says, theoretically, nobody's going to lose any benefits. But if any retired public employee loses benefits because of this act, you would go back to where you used to get the benefits from, and you would be made whole. The problem is, where you would go back to where you used to get your benefits from no longer exists because they've all been abolished. So we pointed this out to the sponsors at, at a hearing. Bill comes out, new bill, it's still in there. And said, this doesn't work. And the idea, the point I raised earlier, it wasn't Commissioner Zucker over at the health department that said, for people over 65, we're going to make them get on their computers, then get in a car and drive to SUNY Plattsburgh. It was the worker bees over at the health department who are still there. And these are the people we're going to trust to reassemble the whole health system in New York State. And we, based upon what we've seen, we have zero confidence. And I have even less confidence, I'll wrap up here, but when I read the newspaper or see on the TV, the state of New York cannot roll out over a 3-year period legal pot. A legal pot program, which should be sort of easy to implement, you would think, which is certainly a lot easier than reassembling the entire healthcare system in the state of New York. If they can't do legal weed, I don't know how they're going to do this.
So drowning mice, legal pot. Nick, anything to add to that before we wrap up?
You're welcome.
I am looking at my notes, and there are, so I worked on the Cannabis Bill, so I have like a real personal, it's like, okay. I could go down a whole rabbit hole. Anyway, one thing on the medical health partnerships that I didn't get to note that I would note is that having legal assistance working with providers has an economic benefit as well, as far as and we talked about housing instability and homelessness, but one thing that we see is that people who don't get health care that they need have undiagnosed issues, or they have issues that they don't have documentation for. And documentation is really important for a whole slew of things. It's important to access disability benefits. It's important and critical to have reasonable accommodations in the workplace. It's important for school children to get IEP services and programs. So I would continue, and I think that's why I'm here, to really push medical legal partnerships and supporting programs like mine across the state that are tying the legal advocacy around access to health and healthcare.
Okay, so we've got
Healthcare
trust and
justice.
partnerships along with drowning mice and pot.
Legal weed.
Yes, there you go.
Stoned drowning mice.
There you go. There you go.
Who need attorneys.
Great conversation.
Well, certainly, Nick, I think, based on some of the conversations from earlier today about social determinants and equity, I think there's probably an opportunity for us as an association to maybe follow up on some of those conversations with you. Ed and Andy, certainly appreciate your, continued support on, a number of, shared issues and interests, and obviously I think we share your concerns on the New York Health Act. But with that, please, give a warm round of applause to Kathy and all of our panelists.
Thank you.